Thank you so much. I really appreciate your time and that you're here. And I wanted to go back to an issue that you raised about longitudinal versus cross-sectional data. And I'm sorry our whole committee isn't here today, but one of our committee members had shared with us, his experience that sometimes it's harder, and I don't know if it's because of FERPA or just other school related protocols, to get longitudinal data than it is to get cross-sectional data. And so I just wanted to hear from each of you the challenges in getting repeated measures over time on the same individuals, and whether that's your experience too.
So I'll just say it's without question harder. It's caused by multiple issues. If you're in the schools, FERPA is an issue. It can be navigated. But for any repeated measures assessment, whether it's surveillance or research, it's harder both to achieve the required authority and the required consent to do repeated measures. That doesn't mean that the application can be circumvented. If a cohort study is what you need to do a study, it doesn't mean that a cross-sectional assessment can substitute for it. So I think it is definitely harder. And over time, I think there's a value to it, because you can see whether you're making an impact on the prevalence of a condition and how kids are moving between different risk categories. We see the Hispanic males and the African American females really spiking in new incidents after they have entered the school population, and we see across the board some kids dropping out, and you only get that in the cohort approach.
I agree, it's much more challenging with the schools. Where we've had some success has been with the WIC population, and it's been very enlightening. We've seen a very different trajectory among Latino children with very early onset high rates of obesity prevalence. The African American population, not so. It doesn't seem to really ramp up until school age. And in a sense, even the prevalence data, though, in that young population is almost like incidence data, because they've been around that long, and in a sense, it's all new onset. I think prevalence can be valuable in that young population, but I think I'd be interested to know what PEDNES could do on a national level to get, data on that WIC population that allows tracking over time. I know we're able to do it in LA County.
Oh, yeah.
I wanted to respond to that because uniquely enough in our Indian community, especially within Cherokee Nation, actually longitudinal will be fairly simple if we had the resources to do it. We have multiple generations living in one home. We tend to stay where we are as in the rural area. We don't have a lot of people moving in, obviously, because it's a rural area. I can see the urban Indian being a challenge. But for instance, I've been working in my community and living close to it working for the Cherokee Nation for 25 years. So it's relatively simple if we have the resources, and even our schools don't see a lot of variation in enrollment. So.
Okay. Thank you.
I want to also turn on the mic. Is that on? No. I also want to thank you all for your time and energy and commitment, obviously, to this issue, which you're all quite passionate about, which is nice to see, since I think a lot of us share that passion. I want to ask you to reflect on the tension that you brought out between the national surveillance and local action. Because I think that's, all politics is local, and when we talk about policy and program planning, you need data behind that. But these data are gathered with different purposes in mind, and they're being used in other ways. And our task here, as I understand it, for our report is to think about how do we know whether trends in data or reports of studies are accurate. And so when you're assessing these kinds of pieces of information which come at you at different levels, it's a leveling question. You're at the local level. You have studies that are local that may not be from your community, but maybe a similar community or even a very different community. How do you know whether to take a study from a similar community and say, well, this one supports what I want to do, so I'm going to use it, or this one doesn't support, so I'm not going to use it, versus taking a national data set and saying, well, this isn't us. I mean, it's almost easier when you can say, well, that national data set doesn't reflect us. But if you have a study that's coming from a sort of similar community, even though it's not your community, what do you do with that data? And what type of pieces of information might you be looking from a framework that would pivot you towards having to grapple with something that you might feel goes against where you want to be headed, if that makes any sense?
Can I respond? It is for the, and I'm a strong supporter of NHANES and all of the national thing, but periodically you have to ask, what are we collecting the data for? I mean, we've done it for a long period of time, but what are we collecting it for? And is it sufficient to the decisions that we have to make? So it isn't hard to ask what decisions you have to make, because you're confronted with them daily. But over time, we find we have streams of data and things that we've done over and over and over again, and have they indeed helped us make those decisions? I think the NHANES has, and it has given us we saw the uptick. Those wonderful charts can be presented and say, this is a national problem. That's important, and it is disseminated across into many different kinds of programs and supported many different decisions. But now when it flattens out, we're confronted with this problem. Okay, what do we do? And we should have anticipated. What do we do when we declare victory? And I think was implied in the earlier part. So if it is, what do we do when we're confronted with a apparent, let's say, semi-victory of flattening out a trend? What do we need next? What do we collect the data for now? And you don't want to destroy the past and the continuity of things. But at some point, you are going to have to determine whether you're going to change the data collection structure because there's a different reason. We've been sensitive to the ability of the national trend of obesity. Now we find we have to be sensitive to other things because it appears that we have done what we were intended to do. Detected a national trend, stopped the national trend. Now do we want to reduce the national trend, and how would we be able to predict that? And so that's unfortunately, that's the problem of your committee. I can't give you the exact, we're supposed to help you with the answers, and I think that we are trying to help with that because it is the prediction of what is going to make the thing change downward.
I think you raise a very interesting and a point and a very important issue. But I guess my question was not about the national trends, but to say, let's say that a study came out from a locality that was similar to yours, but wasn't your community. And it showed, they did intervention X and showed a huge decrease. What kind of a framework, what kind of pieces of information in a framework are you going to be looking for to help you say, this says that I need to do this? Or let's say that they say we did intervention X and it did nothing for us, and you were doing intervention X in your community. What are you going to need to be able to say, I know that this is politically and socially, something that our community is behind, but it doesn't look like it's working, so maybe we should think about putting our resources elsewhere. So I'm trying to take it away from the national level and ask you about studies and information that comes out on a more local, comparable level and what kind of pieces of information might you be asking about?
Lisa, you want to go?
Well, there is a notion of peer counties. There are some data that are reported in HRSA that identify peer counties. So there's it's a topology of 10 or 12 different types of peer county groups. I would suggest that kind of structure of data collection.
Well, it's an interesting question because basically that's what we have to do. There are no studies locally for us or anything related to it. So what we've done is try to look at things that work in rural communities. And then when we get to that point, we try to look at specifically the population based on poverty, based on the distribution of the population in a county or an area, and then the implementation of whatever it was in the process, what kind of processes were done throughout that implementation of the strategy, and to see how parallel that might be with our population.
I would just add, looking at, we have increasing reports of success stories that I think deserve a critical assessment for whether they're true or not. Before I would consider adopting one of their interventions, I think I'd look to see, was it in the same region? I mean, I can't sell something that happens in California and Arkansas. No disrespect, Paul, but it's got to be something from a state that looked like Arkansas for me to be able to sell it. It's got to address and explicitly be successful in lower income communities and communities of color or communities with special populations. If it's successful there, it will be probably successful in the communities of upper income and the majority. And then I'd look to see whether the evaluator was independent from the prime advocate for the intervention. If I've got those three things, I've got a measurement mechanism, I'm open. I think the next step, I think this is a complex issue, and we're not going to find a single magic bullet that actually has a major impact. So it's going to be a multifaceted approach, and to see is there a facet that I'm not already doing that I could add that might make a difference going forward.
Hi, Lynn Blewett. I have a follow-up to that, Joe. In the break you were talking, and I don't mean to put you on the spot, but your Tennessee example of they've showed a downward trend, Arkansas is flat, you don't quite believe that. So it's kind of a real tangible question of what data and information did you use? Where did you get that data that showed there was difference? And then what information would you need to say, oh, that is real, or it's not real?
So I don't think anybody has nobody has done a meta-analysis or a comparison between different studies that have been put out. My constructive skepticism, I would call it, is we for 10 years have been throwing everything that I can think at against this, and we've been measuring every child, and I can't show you a significant decrease in obesity. A state next door to us that has not done as much as we have, and in a short time claims a decrease, I have at least a skepticism of, and I'd like to see the evidence for that. So I think that's going to be the issue. There are significant financial resources or political gain or different currencies to claim that they've been for anyone to claim that their intervention has been successful. I can not count on my fingers and toes the number of commercial companies that have come with the shiny magic bullet that's going to cause the success, and they use BMI as the metric for what their impact is. So I think there is a need to have a healthy, constructive skepticism on quick turnaround success stories, and I think that has an impact on the committee's decisions around the specificity with which BMI is utilized and under what conditions it's deployed.
But what data would you need to say that what is going on in Tennessee is real? And does that data exist today?
Measured BMI by an external independent evaluator.
So none of the existing surveillance?
I don't know what's in Tennessee from a surveillance perspective, from a public health perspective. BRFIS isn't going to reach down into kids.
Numbers. Oh, yeah, BRFIS is adults. We have the samples 1,500 in LA County in one school district for YRBS. But I just to try to answer your question, when I see a trend in LA County, and then I see, gee, Philadelphia reported that trend, New York City reported that trend. We all got CPPW and Community Transformation Grant dollars. We all were doing a lot of work in Tennessee, you guys in Arkansas. I start to then have more confidence in our results that that's something real.
But what data are you looking at? That's where
I'm using data from our school system, measured height and weight. Well, no, and that I wanted to make that point. The RWJ person who spoke at the beginning, I'm not sure.
Tina.
Yes,
Tina.
Hi.
Tina.
Talked about.
Her name's Tina.
Dina, hi Dina. Talked about the fact that there are lots of different ways, things are being done in different ways, which can be a problem, but it can also be a good thing. If we're getting the same result with different groups doing it different ways in different places, I start to feel more confident that something good is happening. And I don't think you can limit an intervention to just one jurisdiction. So as an example, all the publicity around the work that New York City was doing to reduce SSB consumption, I think that had an effect in LA County. I mean, it's everywhere. So it's not like an intervention is constrained by the borders of your jurisdiction.
And let me just try, so Paul's got, if he sees it in LA, Philadelphia, and New York, 3 of our 10 largest cities, then he can have some higher level of comfort. I wouldn't guess that you have complete confidence, but a higher level of comfort that maybe we're moving the needle in the right direction. When I see it reported in Mississippi, which I know that was not necessarily the strongest study, and Tennessee and Arkansas, and I'm not seeing it, so my cohort may not be moving it, where his cohort is moving it, but without the local information to know that, the national data homogenizes it together, and we come to a point where we're not able to really be confident in where we're going.
Well, there is unobtrusive measures of, there are, across every high school in North Carolina, there's this height weight index that's called the football team, and it's in the programs. And actually some people have followed that to find out, to look at trends on that. But you can find the purchases of certain size of gym wear and things of that nature. I mean, we have to be creative in something. Clearly, we're not getting more money on this, but people are going to have to be able to track this who care. So I think we have to be creative in finding the ways in which we can look at that. And if it's in sales of sugar beverages or whatever, maybe that's one way you have to go to give yourself a hint as to what might be happening that doesn't agree with national trend or state trend data.
Can I just finish one thing?
Please.
So, Joe, what you're saying is there's not any existing data that you can look at to say what's going on in these states. You would have another study come in and do some kind of independent evaluation.
No, I think what I'm saying is when somebody reports a success, okay, whether it's a school district or an intervention within a school or a community or whatever, I think the need to actually understand what they're basing that success claim on and what the data underneath that are is critically important. Then I think it's a separate issue, which is that it would not surprise me at all if large cities, because they are more alike than Los Angeles and Arkansas, move together. And it's more likely that Arkansas, Mississippi, and Tennessee move together than it is that one of us moves with Los Angeles. I think you're going to see sub-national forming groups that look alike that have the same experience. That's basically it.
Sure.
Well, being from Tennessee, I can tell you those data are absolutely true. Okay. So I do think it came from coordinated school health data and that repeated cross-sectional measurement. I also think that, as was brought up by the panel, typically when we talk about this, we have central tendency. We're not talking about variation. Typically, when we talk about this, we don't break it into subpopulations. And even when we do break it into subpopulations, they're quite limited. So we might say males versus females, but now I need to look at a male who is Latino, who lives in a rural area, who is 5, versus completely different groups. So the combinations and permutations are almost endless. So it seems to me that the central tendency, that point estimate that we're so used to quoting, really tends to mask what we're learning. And so my question to you is, how should this be presented so that we can get to what would be most meaningful?
So when I think about epidemiologic analysis, we break data down into subgroups to the degree that it would be of interest to the target audience, or to the degree there are distinct differences between those groups. If there are no differences between those subgroups and there isn't a particular public interest, then we lump data together because it's simpler. Right. In addition, in multivariate analysis, we look for interaction. And if there's a positive interaction, then you better dig deeper and see what that interaction is all about. So I think it's just not one rule that holds across all analyses or situations. It sort of depends what you have.
Sherry, I think you just hit on something that is really, really important, which is, and I'll start from if Arkansas's population has had a huge influx of Latino children,
right,
we may have been making great progress, but our population distribution is working against us.
That's right.
So I think there's a need to put at least consideration for either a direct or indirect population adjustment on purported surveillance indicators so that you're actually comparing standardized populations when you look at outcomes of effect.
Right.
I don't believe people are doing that in a consistent or even, I've not seen it done on surveillance mechanisms. And of course, for some groups like the Cherokee Nation, it wouldn't be appropriate. But for a geographically determined group of individuals for which you have, multi demographics in it, then I think it would be appropriate to do a population, either direct or indirect adjustment, so that if you're comparing one community with another, one state with another, you're actually making it be apples to apples on what's going on and neutralizing some of the population distribution effects that might be having an unrecognized influence.
I'm not sure this is relevant, but I'm going to go ahead and say it. And I'm thinking a little out of the box based on on-the-ground experience, but unless you have a tremendous amount of resources, I know how difficult it's going to be to get down to those sub populations.
That's
One thing that's always struck me is that we do a lot of cooperative agreements with CDC. It's not a research project, but it's time to think out of the box. NIH, CDC pair together, have community-based participatory research going on at the same time that we're doing the intervention, because a lot of our progress is based on what YRBS or BRFIS says at the end of our particular cooperative agreement period. So I see that we have lots of community involvement and willingness to collect information on all kinds of other things that are going on, but not necessarily for research purposes in our cooperative agreements. It's time for us to figure out how to partner with some scientific organizations to start really looking at that from a truly community-based participatory stance.
Mm-hmm. Good, thank you. So I'm just building on this notion of, is it meaningful? Because what you all have been talking about up to this point is it true? So, and what's the lens in which you would gauge whether you could say, is it true? So Joe doesn't believe me about Tennessee, that's okay. But is it meaningful is the second part of that question. And what I mean by meaningful is that when you look at data, it'll say up, down, the same. Better, worse. But really, and you all have brought this up, you really are interested in what's the absolute change, not the relative change, and what absolute change would matter to you as policymakers.
I have a quick answer, just a real quick answer to that. It really doesn't matter what's meaningful to me. It's just what's meaningful to the people who are the decision makers in my community. And to them, it's locally collected that they're invested in. They believe that, and that is meaningful to them based versus something national or.
But is it a 2% absolute change? Is it a 5? Is it a 10%? What is meaningful? Because right now, the way that we report these data, we say better, worse. Or we'll say 43% reduction, when actually, if you looked and broke it out and said, and I'm looking at Latinos because I study that with my research. So if I look at Latinos who are 2 to 5 and I look at the same data set, there wasn't any change over the years in the report that came out in 2014, but that wasn't the headline. The headline was 43% reduction in early childhood obesity. And so that's what I mean by this notion of relative versus absolute, and then what matters? What do we think actually matters? And I'm looking at you all as sort of decision makers, policy makers connected to your communities.
So Tina kind of said it at the beginning, where the RWJ goal is 2025 to get down to, about 5% or so. And I think one of the reasons we're debating all of this today is because the changes have been so minuscule, not really meaningful. In our YRBS data on tobacco use, in 1997, 25% of high school kids reported smoking. We're now down to 6.7%. And that's meaningful.
Yes, right.
So I think we have to, from a policymaker standpoint and a community standpoint, I think we have to be talking about more than just a percentage point. It's got to be a few percentage points sustained per year. We're not even close to that yet.
So I'm going to go out on a limb. This is Joe's political crystal ball. You give me 2 years in a row that we have a reduction, I'll take any reduction. And then after that, I need 1% a year. I can keep things going if I have that. And it's always, it's going in one direction. It's a reduction 2 years in a row. I'll take 0.5%. But by year 3, I got to have 1% a
sustained.
year so that I can maintain political support for the level of engagement.
Huh, interesting.
You also ought to refer to the Healthy People goals and that process of developing both realistic and stretch goals for states and the nation. In the health rankings, both the national one and now the county health rankings, that's become a very intense, let's say a focused project of really having people set goals to see what they can be and having the goals be somewhat customized because a national goal may not be achievable at a local goal. And then there's, of course, the compression of achievement that when you get up to 98%, it's harder to get the last 2%. So people have to understand where they are and where they want to go on that. But a certain amount of democracy and goal setting might be useful in this, and that a certain division into either regions, localities, counties, or whatever would be useful in that process. The thing that might resist that is the degree to which really NHANES and national measures tend to be isolated in themselves, that they don't want to be muddied by anything else. And that's good because it gives them, you know how to relate to them. But then the interpretive process needs to have a marketing aspect to it so that people can understand that. So again, I think the Healthy People process has learned a lot. Healthy Americans, the Healthy this, that, or the others have learned a lot about what are the kind of goal-setting structure you should do in order to understand what you've done. I'd say a lot of that has been failures, but then we have learned, if we will go back and look and say, let's learn from what we did wrong in the past on that.
Thank you.
A question about infrastructure, and you're all here, and in part you all have a very strong research focus, and so I'll stick up for Mississippi, since we have an Arkansas native on the panel. But, so this local message is getting across really loud and clear. And I wanted to know, we've heard about things in these paradigms about consideration of dropout and paired designs versus independent designs and assessing linear and quadratic trends in time. And I wanted to get your input on what the infrastructure you have at the state and local level for addressing issues like that and what infrastructure needs might be.
Well, usually there's more infrastructure than you know that gets ignored a lot. In state epidemiologists and data centers, there tend to be people who are able to do this but are somehow constrained by either politics or let's say the conflicts with the policies that are predominant. I think they also get, they're interfered with more often by academics than they're supported by academics. And being an academic, I can tell you that I can see that happen all the time. And I think that there ought to be some sense of better collaboration with, between the academics and the departments, the health departments. But we have a lot of health departments out there. We have a lot of people who understand the epidemiology, understand the problems of rates and change. And I think we're underusing them. You guys are real good.
Well, in LA County, we're fortunate to have a really strong staff of epidemiologists and close working relationships with USC and UCLA. But most of the local health departments across the state of California, at least, that I'm familiar with, don't have much infrastructure. And I think they really rely on, academics, and I think the state health department. And there's some actually very, very accomplished community organizations and foundations, I think, that can provide lots of technical support. But I don't think most local health departments or the average community-based organization can do the types of things that were being talked about this morning.
I think there is incredible local intellectual commitment, which I would count as infrastructure. I think there is incredible variation within the public health community. North Carolina, each county has an independent health department. In Arkansas, everything is centralized in the central health department. Our state health department probably is small compared to Los Angeles' health department. So just great variety there. I think the more important thing is the difference in currencies. The academic environment has the academic currencies that the public health department and the political environment candidly don't value. So there is a tension between the collaboration between the academics in the public health space and the policy space, because the policymaker is going to have the question next week or next month. And they need to have the answer that you may have now, but it's in peer review. And those are two inherent, incongruent currencies. And I think that's really the space that if you can bridge, which I think we in part have done, not completely, but we in part have done, is to say, okay, we're going to subject the academic currency to the political need. We're still going to get some academic currency out of it, but it's not going to be nearly the number of publications because we want to affect change first. But that's a different paradigm than I think most local academic infrastructure comes with.
We're just about out of time. I'd like to take this opportunity to thank our panelists. This has really been terrific and a real, I think, broadening of the perspective of the committee in terms of the importance of taking the local perspective, not just the national perspective, and giving us some ideas of ways in which that might be done so that we could eventually have a report that reflects it in an important and meaningful way. So I'd like to say thank you to Lisa, to Tom, to Paul, and Joe. This has been terrific. Thank you.